Hi everyone, and thank you for coming to our presentation. Before we begin, I would like to start by acknowledging the Wurundjeri and Bunurong people of the Kulin Nation as the traditional owners and custodians of the lands on which we live and work, and also on which this research took place. I pay my respects to their elders past and present, and acknowledge that sovereignty has never been ceded. My name's Phoebe, and today Dr. Young and Claire Lee, Professor Felicity Baker and myself will present the results from the Australian cohort of the Middel International Cluster Randomised Controlled Trial. I'll start by giving a little bit of background to the trial. Claire will then present the trial design and results, and Felicity will discuss the findings and their implications. So Middel is an international trial led by Professor Christian Gold from Norway and involving 6 countries. The Australian arm of the trial, which is led by Felicity Baker, was the first to receive funding and it's the first to finish, with the remaining countries not due to complete the trial until 2023. Here in Melbourne, we officially began 3 years ago in June 2018, and before COVID were due to complete the music interventions in September last year, with the final assessments in February this year. However, due to the ongoing lockdowns and the significant impact of COVID-19, especially in residential aged care in Melbourne last year, we stopped the trial early. So the Middel study addresses a gap in the literature regarding the clinical and cost effectiveness of music interventions in residential aged care, specifically in addressing symptoms of depression experienced by people living with dementia. It is well recognised that the experience of moving into residential aged care involves life changes that can be disorienting and disempowering for people living with dementia, and that the experience of living in care homes can impact residents' social, emotional, and psychological well-being. There is increasing evidence that music interventions may be potentially promising non-pharmacological approaches to increase positive, meaningful interactions and improve well-being and quality of life. This trial examines the effectiveness of 2 of the most widely used and studied music interventions with people living with dementia, which are group music therapy and recreational choir singing. So in this trial, GMT, or group music therapy, was designed as small, closed groups facilitated by a registered music therapist and taking place where possible in a private space at the aged care home. GMT focused on residents' identity, validating emotions in the here and now, connecting with others, mental stimulation, and meeting the psychosocial needs of each resident within the group. Sessions involved familiar song singing, reminiscence and discussion, playing or improvising on small percussion instruments, as well as spontaneous or directed movement to music. Contrastingly, the RCS sessions were designed for larger open groups and took place in the central communal lounge areas of each care home. Sessions were facilitated by community musicians and involved short, structured warm-ups before focusing on familiar song singing with lyrics displayed on the screen. RCS involved a combination of cognitive, physical, and psychosocial processes and aimed to promote social interaction, enjoyment, and activation of positive emotions through these structured, leisure-based singing activities. So I've described some of the differences between the interventions, but I also just wanted to highlight some common characteristics of GMT and RCS. Firstly, and importantly, both interventions delivered within this trial were developed by a team of experienced music therapists. Both GMT and RCS interventionists also received training and ongoing supervision from experienced music therapists. All sessions were 45 minutes in length and were delivered twice weekly for 3 months and then once weekly for another 3 months. And both interventions did involve familiar song singing, though to different degrees, and the repertoire and experiences were tailored to the participants' preferences. So the main aims of the Middel trial were to examine the effects of group music therapy versus no group music therapy, recreational choir singing versus no recreational choir singing, and the interaction effects of both on symptoms of depression for residents living with dementia. And in addition to those primary aims, examining effects on depression, we looked at neuropsychiatric symptoms of dementia, and the trial also tracked changes in medication use, the quality of life of residents, staff members' experience of caring, and the cost effectiveness and cost benefits of delivering the interventions in the care home setting. Okay, I'll now hand over to Claire to discuss the trial design and results.
My name is Claire, and I'll be presenting the methods and results of this study. The cluster randomized control trial uses a 2x2 factorial design examining the effects of music interventions over 12 months. In Australia, we aim to recruit 500 participants from 28 care home units. We implemented a staggered rollout, commencing 4 new care home units every 3 to 4 months. However, we only began or completed sessions with 20 care home units across 10 residential aged care homes due to COVID-19 lockdowns and outbreaks. Resident inclusion criteria were that they were 65 years or older, had a clinical dementia rating score of 0.5 to 3, and a mini mental state examination score of 26 or less, and at least mild depressive symptoms. Staff were also recruited as participants in the study on the basis of working at least 2 shifts per week at the time the site was randomized. Our primary outcome measure was Montgomery-Åsberg Depression Rating Scale, which measures depressive symptoms. Our secondary outcome measures included the neuropsychiatric inventory, quality of life Alzheimer's disease, EQ5D, service use, and professional care team burden scale. These outcome measures were designed to measure neuropsychiatric symptoms, quality of life, and professional staff burden, as well as cost effectiveness. Between June 2018 and January 2020, we had 20 care home units participate in the study before COVID interrupted recruitment of care home units 21 to 24. Due to extended lockdowns, recruitment was discontinued. Despite having to end the trial early, we screened 818 residents across 20 care home units and recruited 318 residents and 131 care staff. 1 care home unit, including 7 staff and 28 residents, were lost at the primary endpoint during follow-up due to COVID lockdown. We were impacted significantly by COVID lockdowns across all care homes that had not yet completed the study, and sadly, there was even a COVID outbreak in 2 of the care home units. You can see the impact of the COVID-19 lockdowns here, which extended from cycles 3 to 6, interrupting either the intervention period, represented by the coloured rectangles, and or assessments, represented by triangles. This table shows the main demographic and clinical characteristics of our resident participants. Most residents in our study were female, with a mean age of 86.5 years. We found that the demographic profile of our participants were similar to those of residents in Australian residential aged care. There were no significant differences between any demographic or clinical characteristics between the groups. This is a table of results from an earlier study by Werner and colleagues, which formed the basis for our Middel trial. Werner and colleagues examined the effects of 12-week music therapy and recreational singing on symptoms of depression with elderly residents with and without dementia living in residential aged care homes. As you can see in this table, the level of depressive symptoms improved for participants assigned to music therapy at 6 weeks. Similar pattern was observed at 12 weeks. Coming back to our trial, our primary statistical analysis of effects showed that RCS was superior to no RCS at all time points. GMT was not superior to no GMT, nor was there a significant interaction effect of GMT and RCS. The key results to note in this table are highlighted in yellow. Analysis of secondary outcome data on the neuropsychiatric symptoms found RCS was superior to no RCS at 3 and 12 months only. With respect to distress of neuropsychiatric symptoms for caregivers, GMT was superior to no GMT at 3 months, and RCS was superior to no RCS at 3 months and 12 months. The findings suggest that both interventions had beneficial effects. Again, the key results are highlighted in yellow. We conducted secondary analyses, including only the subset of residents with moderate to severe dementia. Effects of interventions were larger, with RCS being superior to no RCS at all time points. Unlike findings among the whole sample, GMT was superior to no GMT among the subsample at 3 months.
Recreational choir singing led to a clinically meaningful reduction in depressive symptoms at 3 months, 6 months, and at longer-term follow-up. Recreational choir singing was also found to significantly reduce the severity and distress caused by neuropsychiatric symptoms at 3 months and 12 months. These findings were in contrast to the smaller scale study by Werner and colleagues that informed this Middel study. Group music therapy improved distress caused by neuropsychiatric symptoms at 3 months. We found smaller, non-significant yet meaningful effects on depression. Further analyses suggest that group music therapy may be more beneficial for people with later stage dementia, which is in line with the Werner and colleagues study. Combining group music therapy and recreational choir singing did not increase the effects further, instead suggesting a saturation effect where further beneficial effects cannot be reached by offering both interventions together. Effect sizes show that the recreational choir singing had a larger effect size compared with the Cochrane review of music interventions at the end of the intervention and at the long-term follow-up. Our findings suggest that both music interventions seem to have a larger effect on those with more progressive dementia. This suggests that when working with people in residential care, when resources are limited, priority should be given to those with more severe dementia as the benefits are larger. Those in the earlier stages of dementia are often able to participate more actively in other leisure activities, whereas those with more severe dementia may not. Our findings show that music interventions with a larger component of singing lead to stronger effects on decreasing depression than those that involve other music activities, such as improvisation, music-stimulated reminiscence, and movement to music. It could be hypothesized that this is largely because singing is tied to the experience of fun and may have a lesser cognitive load on the participant than more complex music activities. Our findings suggest that group music therapy is more beneficial for people with later stage dementia, which highlights the need for more specialized knowledge in working with people with complex care needs, and suggests that when aged care services are resource limited, these patients should be prioritized in being offered access to music therapy. It is important to note that recreational choir singing program was designed by music therapists, and the recreational choir singing facilitators received training and regular supervision from experienced music therapists who assisted them to consider repertoire decisions, understand positive and negative responses to music, and develop skills in empathic and client-centered care. The clinical implications are that recreational choir singing is more scalable, as the delivery of this intervention is not limited by the availability of facilitators that require extensive and specialised training. These findings are timely, as the Australian Government is currently revising the aged care policies and funding models in light of the recent Royal Commission into Aged Care. The Commission's recommendations were that music therapy programs be included as a compulsory service of every aged care provider. Our findings, therefore, have important policy and practice implications. In conclusion, this cluster randomised control trial of 2 music interventions showed that both group music therapy and recreational choir singing were beneficial for care home residents with dementia and depressive symptoms, although only recreational choir singing was statistically significant. Singing led to clinically important improvements in depression, neuropsychiatric symptoms, and generic quality of life. The more specialised and therapeutic intervention of group music therapy did not yield the same effects of the whole sample, but was beneficial to residents with more severe dementia. The preliminary results from our Australian cohort confirm the feasibility of the larger international trial.